from the American Academy of Pediatrics.
June is National Gun Violence Awareness Month, and the AAP is advocating for changes in legislation.
One pediatrician and mass shooting survivor is using her own story to make a difference.
I looked up and saw a stampede of people rushing towards me and smoke kind of billowing overhead. And immediately, my instinct was to find my children.
Plus, research on an electronic survey for adolescents shows promising results.
And then the teens, they pick up the tablet and kind of walk away from their parent. And we knew we were onto something when we saw that. Or they kind of hold the tablet away so the parent couldn't see it.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about protecting kids from gun violence.
Because children are our future, so many pediatricians unwittingly find themselves doing advocacy work. We as a profession know that the health of patients is so tied to the environments they grow up in.
Unfortunately, the United States has now become an environment filled with guns. Firearm injury is the leading cause of death in children and adolescents in our country.
It's also very easy to get a firearm in this country. I feel like it's easier to buy and use a gun than it is a car. You don't need a license. There are no registries or ways to track your purchase. Additionally, there are few regulations on what guns you can buy or how to store them when you do.
The issues you just mentioned, Joanna, are all gun reform measures our next guest has not only thought about, but tried to change. Dr. Emily Lieberman is a general pediatrician in the suburbs of Chicago. She is the founder of On Call for Kids, a grassroots advocacy group whose mission is to ensure that children are no longer victims of gun violence. Dr. Lieberman, welcome to the show.
Thank you so much for having me to discuss this very important topic.
Emily, I know that beginning your advocacy journey on firearm injury was very personal for you. Can you share that story with us?
Yes, absolutely. I originally thought I advocated for firearm injury prevention for children just by talking about it in my clinic as a general pediatrician, talking about secure storage with my patients and parents. But I never did much more than that. And I was fully satisfied in my life as a pediatrician and wife and hadn't planned on doing much more on the advocacy front, to be fully honest with you. On July 4th of 2022, I went to our town, Highland Park's July 4th annual parade. I'm a Highland Park native, and I've been attending this parade since I was born. And this year was particularly special because COVID had canceled the parade the previous 2 years. So I had my little girls dressed up in red, white, and blue, and we had American flags and fireworks all over our arms that I face painted, not well, but I did it. And we were so excited to celebrate my favorite holiday of the year. We went with 13 members of my family, as we do every year. So it's grandparents, cousins, the whole lot. And in my idyllic town on this most patriotic day of the year, my children were in the street gathering candy, waving to neighbors and friends. And 10 minutes into this event, all of a sudden you heard popping noises overhead. And it was very quickly very clear that my town was under attack. I looked up and saw a stampede of people rushing towards me and smoke kind of billowing overhead. And immediately my instinct was to find my children. My husband grabbed one in the street and I went to grab my younger daughter. And then in this stampede of humans, we got completely separated and I lost him. My last image was him running away. In my head, thinking, oh my God, I don't know where the shooter is. I hope my daughter and my husband don't get shot in the back. And at the same time, I was trying to shepherd the family that was near me and not able to walk as well out of the way with my youngest daughter. I lost my shoes while I was running through the stampede, so I was barefoot on the sidewalk and ultimately pushed my mom and my stepdad, who couldn't walk very fast, into a storefront, the first storefront I could find. And we ran all the way to the back and found a single occupancy bathroom that ultimately held 17 people in that tiny little bathroom, where the adults basically sat on top of the children so that we could use our bodies to shield them. And we sat in darkness for 2.5 hours. Of course, my daughter at first was crying to go home, and I begged her to stop crying, that mommy would try to keep her safe when I didn't know if we would live. I tried to call the police that moment to let them know where we were hiding. I was on hold on a busy signal for over 10 minutes, and then I stopped trying. Needless to say, it was the scariest day of my life. I am so grateful that we are alive, but we are absolutely forever changed. And I made a vow that day in that room that I would spend the rest of my life, if I survived, trying to create change and prevent this from happening to other communities, not just focusing on mass shootings, but everyday gun violence that I wasn't addressing fully enough as a pediatrician in my clinic.
I cannot even imagine, Emily.
Yeah, I have 2 daughters, so that really just hit hard.
Yeah, it was rough. And I then had this unique, unwanted position as a mother of 2 young children, as then a survivor of someone going through this, and then as a pediatrician in the community, trying to play many roles in the aftermath of this event, trying to protect my children, and then realizing I can't protect my children in the way that I wanted to.
Emily, Joanna mentioned issues like a lack of background checks, absent gun registries, and minimal regulations on types of guns purchased and storage of those guns. Are these the legislative priorities pediatricians should be trying to address? And if so, how?
I do think those are exactly the types of priorities we should have. These issues are not political. They're not partisan. Almost all of America wants this. Certainly greater than 50% of Americans, when polled, want these pieces of legislation. This is common sense to keep children safe. Background checks. You need a license to buy a car. You have to apply for a mortgage to buy a home. There's no reason that you shouldn't be deemed safe and appropriate to have a firearm, which is something that could kill others. It only takes mere minutes for a background check. This is not infringing on rights. This is keeping people safe. Secure storage. We have millions and millions of children who live in homes where guns are unlocked and loaded and available for children to reach. That is completely unsafe. And there is no reason that it shouldn't be a requirement to keep your firearm locked and unloaded with ammunition separately stored. This is basic safety for our nation's children.
I'm glad you mentioned, though, that there is a polarization of issues like gun reform in the United States. Some are very for it. It seems more than half. Some are against it. When it comes to addressing these strategies, what's the best way that we can all agree and come together on them?
I think that the most important message is that we are not coming after people who own firearms, and we all want to protect the Second Amendment. I think that the way to address this is to come at this with facts and data and science and treat this as the public health crisis that this is. Gun violence is the number one cause of death of children in this country. We need a solution. And while it is going to be many components to create the solution, improved legislation is most certainly going to save lives. And we have the research and data to prove that.
You know, you mentioned facts and science, Emily. It strikes me that we spend billions of dollars researching causes of death that are less common than gun violence. What sort of research would you like to see when it comes to gun violence in children and the reforms that would keep them safe the best?
I think that there is more research that I want to see than you have time to let me answer on this podcast. There are decades worth of research that wasn't able to be accomplished and properly funded due to the Dickey Amendment.
And can you give us a quick description of what that is?
Absolutely. In 1996, the Dickey Amendment was created, which specified that none of the funds made available for injury prevention and control at the CDC could be used to advocate or promote for gun violence control. Unfortunately, this passed because of the political landscape of the time, but this left a tremendous deficit in funding for research. Because of that lack of funding, we have huge gaps in our knowledge. We have gaps in research databases that leaves us unable to help find the cure to end this deadly epidemic. We need to invest in funding to help learn about community violence intervention programs, hospital-based intervention programs, school, all these different facets that we haven't been able to properly devote enough money to research, and to also improve which types of legislation would be important to pass. We need research to help continue to find those facts.
And certainly we all need to work together. Have you been surprised by support you've received from any unexpected partners in this journey?
I was very excited to be welcomed with open arms by the American Academy of Pediatrics. I had been a member forever, but mostly that was just paying dues and never sought a higher level of involvement. But as soon as I experienced this tragic day on July 4th of 2022, I reached out to the AAP and they helped me elevate my voice and find a platform to start my advocacy work.
Emily, given the work that you've done in advocacy around this topic, do you see change as being possible?
I absolutely see change as being possible. I definitely think that we are on the cusp of big change and embracing the fact that children should be safe to walk to school. We should be safe to go to movie theaters. They should be safe to go to 4th of July parades and other community events. They should not be afraid to sit in their classrooms and learn. And for this reason, I am certain Americans will take this issue very seriously and move forward to create a safer country for our children. I am proud of the country I live in. I'm proud to be an American, and I know our country wants better for our nation's children. And I know that we will stand together to fix this horrible epidemic. It's going to take the American public to show that this is an absolutely important voting issue. It's going to take the American public to show that no matter if you're Republican, Democrat, or independent, you want to protect your nation's children. And we will only create change when all of America bands together to do so.
And for pediatricians who are interested in talking to politicians, either in their local communities or at the national level, what are ways they can connect with advocacy?
Yeah, I want to be totally honest by saying I really didn't know anything about politics before July 4th of 2022. I didn't know any of the senators or members' names in Congress. I certainly didn't know what they'd look like. And talking to one of them would have been something I would have run away from. So I don't want people to think that you have to really have a good understanding of politics to be an advocate. All you need is passion. And I think that as pediatricians, it is our role and our sworn oath to protect children. And therefore, we are the most fit to have this conversation. We are the most knowledgeable about injury prevention for children. And we don't need to have any wealth of knowledge of politics. We just need to speak to the heart about protecting children. And our message and our research and our personal experience is very meaningful to politicians.
Emily, I would love to join you one day at the Capitol, so I'm going to be following everything you're doing next. If you had one takeaway for our listeners about gun safety reform in this country, what would it be?
I would ask everyone to look up their particular legislators, both at the state and federal level, and find out, are they in support of gun safety legislation? Are they sponsors or co-sponsors of bills? If they are, call them and thank them. If they are not, call them and say, why not? Why are you not sponsoring a bill to protect our nation's children.
Dr. Emily Lieberman, thank you so much for joining us today.
Thank you so much for having me.
To learn more about how you can incorporate advocacy into your practice, visit our website at aap.org/podcast.
Coming up, we'll look at how an electronic survey is changing the way teens report risky behaviors.
David, how often do you find yourself going into your teenager's medical records? I imagine it's tempting to do that now that everything is available electronically.
Oh my gosh, I would never. I am so sensitive when it comes to maintaining my children's autonomy and confidentiality. I sent him to my former practice partner, Dr. Pollack, and I'm like, good luck in there. But of course, I see where people get tempted. But no, there's some things I don't want to know.
Well, all pediatricians, though, need to be talking to teens and screening for these health topics, especially if their parents are reluctant to kind of dive into their charts and see what's going on.
Oh, gosh, they do. And so we need something that can both protect adolescents' privacy, but also give them the time and space to talk about what's on their minds as they mature. I think you'll be excited about our next guest, whose work involves helping us get that information. Dr. Brian Jenssen, first author on the paper, Accelerating Innovation in Primary Care to Support Adolescent Health Discussions.
Oh, we have Dr. Jenssen back. I remember when he joined us to discuss protecting children from tobacco and nicotine back on episode 154. And just to remind our listeners, he's an assistant professor of pediatrics, a practicing primary care pediatrician at Children's Hospital of Philadelphia, or CHOP, a faculty member at CHOP Policy Lab and CHOP Clinical Futures, and the medical director for value-based care for CHOP's Care Network. Dr. Jenssen, pleasure to have you back on the show.
Thanks so much for having me.
Brian, we hear a lot from our colleagues in primary care practice that they don't feel like they have the time to do all the screening and anticipatory guidance they should. Is that the problem you and your team were trying to address?
Exactly. For the last 20 years, even longer, there's all these reports in the literature about how do we best routinely and systematically capture more information from teenagers to better support them. We keep talking about having to have confidential discussions, which is great, getting the parent out of the room and then talking with the child to not just talk about health risks, but talk about health strengths, talk about identity issues, the range of things that teenagers are facing so we can best help them. The problem is we hadn't moved the needle over the last 20 to 30 years. When you actually talk to pediatricians, and I understand this because we're pediatricians and I try to really understand the problem that people are facing to develop the right solution, it's a struggle to get the parent out of the room for a period of time and have these confidential discussions. Teenagers want it. They want to talk to the pediatrician. The parents want to talk to the pediatrician as well and want the teenager to talk to the pediatrician. But it's a struggle, and we weren't really operationalizing the best approach.
So, Brian, let's look at what I know I have been doing in practice, and I think a lot of my colleagues do, which is we give our teen patients an adolescent health questionnaire, or AHQ, like the GAPS or PHQ-9 to fill out, and then we try to review their answers with them in person. How well is that working for pediatricians in practice?
It's a great concept, and when you can implement it well, it could potentially work. So pretty much all humans, especially teenagers, prefer to answer questions about their health on a paper form, some sort of format before they go in and see the doctor, ideally electronically. One of the barriers, though, is how do you translate getting a simple thing of moving the paper from the teenager through the office to the pediatrician to then review it with the teenager. And that's where we came in with kind of our solution.
And your solution included taking this screening form, making it electronic, and then integrating it into the health record. What made you feel like that was going to work better?
What we took, that actually you mentioned, David, the GAPS, we took a variety of what are evidence-based and kind of validated questionnaires and combined them into one questionnaire. And we really invest so much of, I have many weaknesses. The strength is I'm not afraid to learn through doing. So we said, well, here's our hypothesis. If we somehow put this into an electronic format, had the team complete it, and then got that answers to us in an easy-to-review system before we went into the room, it would really improve clinical efficiency, increase disclosure of the teenager, and then going to lead to improved outcomes. And so we just tested. I was actually our first test doc. We tested with a couple of my teenage patients. They liked it. And then we knew we were onto something because my colleagues at one of the clinics we work at said, Brian, what is that? I want that. That is awesome. If you can kind of keep that as integrated as possible, maybe help me with a little documentation. Oh my God, you're onto something. And that's what we did. What we really did was we took an electronic health questionnaire that the child completes ahead of time. And we'll go into a little bit of the confidentiality issues because we have to play some whack-a-mole with it, but it works well to have the child complete it ahead of the visit. So then when you can review before you go in, when I would train and still train residents and med students, I'd say you kind of, when you did the face-to-face questions, you ask them about the whole, people use different acronyms. Some might use HEADS or SHADS to guide the questions you ask, or SHADES. You're kind of waiting for the shoe to drop. You're asking about it, and you kind of have to pause when they have a positive answer to whatever you're focused on. Here, what's so great, another huge value add is before you walk into the room, you can see, wow, this child looks like there's concerning issues in terms of potential depression, and they're engaging in high-risk sexual activity. You wouldn't have gotten that because you probably just focused on the depression. Here, you can get all that content in before you actually go into the room.
I can already see how useful it is to be able to prioritize ahead of time. How did you determine what questions needed to be on your adolescent health questionnaire?
We took what was the GAPS questionnaire, again, some of these validated questionnaires, and then we said, well, we also have our preferences. Once we went past the first testing with me, we kind of talked to our other physicians, what else do you need there? And we were open to not using validated questionnaires, but questionnaires that might just be helpful to get more information. And we focused on a range of domains of things that we wanted to kind of get more information of because we think we could intervene around.
And you mentioned earlier the whack-a-mole, I love that, with confidentiality issues. How did you build trust with your teenage patients that this was going to be okay?
Yeah, another example of learning through doing is once we went live at one clinic, and this whole, what we talk about in the article is how we scaled it up across our whole primary care network, not because we're tremendous innovators, but because we kind of sat and listened to people and focused on the problem and developed the right solution. So when we first tested at one clinic, we also did observations of the teenagers in the waiting room, and we didn't tell them we were doing that. We just kind of had some of my staff kind of walking around. And what we emphasized in the questionnaire itself, we said, this will go to your physician provider, and we're not going to share this with your parent. There's a variety of ways of describing that, but this will remain confidential. We went through the rules of confidentiality and when we might break that confidentiality, and that we'll do our best to keep this and only have this with your healthcare team. And we knew we were onto something, again, early in this process, where we'd watch, especially the older 15, 16, 17-year-old children. You complete right now the questionnaire on a tablet. And I'll go into some of the technical issues for those listening, but you can put it on a tablet when the child comes to the visit. And then the teens I know we're on a audio format right now, but they pick up the tablet and kind of walk away from their parent. And we knew we were onto something when we saw that. Or they kind of hold the tablet away so the parent couldn't see it. And we were saying, what teens actually disclose? But almost overnight, when we went live, we had pre-existing data at one of our clinics that was, we think, doing regular confidential visits. Almost overnight, the patient population didn't change, but the reporting went up dramatically.
And you mentioned technical issues. Do you want to go into those? What did you experience with the tablet?
Well, I think we all have frustrations with the electronic health record, period, right? That's not a profound statement. The electronic health records just weren't built well for the dynamics that we face as pediatricians. This very academic term I like to use, but silly, but it's descriptive, triadic relationship, right? We're both taking care of the child, especially when they're younger, we're really taking care of the parent and the child. And as the child ages, there's more of that relationship with the child. And we kind of need multiple different ways of communicating with the teen and the parent. What we learned is we can't send the questionnaire ahead of time, ahead of the visit, because even on accounts, and I caution this for all the listeners, even on accounts that say the child is the account holder of whatever you're using in terms of a portal to get access to the child ahead of the visit, the vast majority of the time it's not the child, or the child has unintentionally or intentionally given that account to their parent. And most parents, the vast majority of parents, don't have ill intentions, but we couldn't guarantee that it was the child actually completing this. So by doing this on a tablet, we can guarantee that it was the child completing the questionnaire for the vast majority of the time. And then we had better data security so we can ensure that this doesn't go anywhere else. The content that gets ingested isn't released. It's not released in any format, and we keep it confidential, even if a parent would have a request of the record. And that's well within bounds in terms of 21st Century Cures Act and a variety of the state laws in place to protect confidentiality.
And you mentioned you got a lot more data from this electronic tool. So does that mean that you felt like it was better than the previously used paper or in-person interviews that pediatricians are doing in their office?
Yeah, this whole effort was born out of frustration with, as you mentioned, Joanna, that I was here talking around, I do a lot of tobacco control work to help parents quit smoking and help protect teens from all the range of tobacco company abuse targeting them. E-cigarettes, a huge issue that we all face. It was we think it might have been an even bigger issue in 2018. So in 2018, we used the power of our large care network. We had a randomized control study that we were recruiting for, and we were using what we thought was a reasonable way of screening teenagers in a confidential way for tobacco use. And we discovered we had to close the trial, and actually it was a failed trial because we couldn't recruit the teens, because despite the school-based surveys at the time suggesting 18 to as much as 25% of children were reporting regular e-cigarette use, only 1.8 to 2% of our teens reported e-cigarette use through our current confidential approach. So our team said, well, either our teens are perfect or we're missing something. And what we did was we did observations of how people were conducting current, in quotation, confidential visits. And we discovered it was often a nurse asking a teen a question about tobacco with the parent right next to them for the range of questions we're supposed to be asking. So we used that when we started going live. We had some good baseline data that we knew was flawed. And overnight, tobacco reporting went from 2% to 10%. And we had all these other things. We knew about, for example, another domain that we focus on, reproductive health. We knew that about 15% of our children were reporting sexual activity at our clinics who were doing confidential visits. It was probably more like 5% at some of our clinics across our primary care network. Now, again, after 1 month of data, unsurprisingly, because more kids are similar than different, the rates of sexual activity reporting went from 5% up to 20 to 25%, and then increasing with age. So we kind of learned quickly that, yes, we think we were onto something because the rates of reporting went up.
And Brian, for those of us who are not lucky enough to work in one of your project clinics, how should your results inform what we do in our own clinics?
Yeah, great question. I think 3 responses to that. We have technical savvy to kind of work through some of these problems, but I think we're helping figure that out. And it can be simpler than what I've even described here. One, I mean, if you write the right system, it can be a paper-based system. That's okay. In many ways, in 2024, it's intriguing that actually might be more data secure than relying on an entirely electronic format, which is kind of, an interesting thing to say in 2024. But there are a lot of the electronic health records allow this. You can actually use pre-visit questionnaires. I think we just have to work through is having the will. So the second part is, are people nervous because parents are going to be upset by this? We've seen that not to be the case. Now, we capture a lot of content across a range of domains that includes sexual orientation and gender identity. Gender identity gets certain parents revved up. But last year in 2023, we completed approximately 60,000 questionnaires. So 60,000 teenagers completed the questionnaire last year in our care network. And we gather all this information. We talk to our practice managers and our medical directors. We look through all our Press Ganey data. And as far as we can tell, we've had 5 formal complaints. So that's a complaint rate of what? 1 out of 12,000 almost.
Wow.
So the second point is that the barriers are probably our own ascertainment bias of thinking that parents are going to be upset by this. But the vast majority of parents want to be supportive. And when we say if a parent doesn't want to do it, we say your child doesn't have to complete it. But the parents usually do. And the final one is it really helps identify practice change. You can identify one more reason to do this besides increasing the efficiency of your visit, getting more information. Most kids are negative on a range of issues. So you get to talk about all the other things you want to talk about with teenagers or all the successes they're having. But when there are problems, it can help you figure out as a practice, as a care network, as a health system, where you should develop and push more resources to best help teens.
And I know our listeners are going to want to read this study and maybe start engaging teens in a different way. But before they do, any last takeaways for them?
Dive in. I would say learn through doing. I think this is such a great effort we had a lot of hypotheses that could be tested. And if we kind of work through all our hypotheses, I don't think we would have ever moved forward. So it was all iterative, which we briefly describe in the paper. And it really just started, it was born out of frustration, born out of literature that's saying we really weren't moving the needle. And what we did was we just started with one physician, a couple of patients, and it quickly scaled up. And it's a credit to the almost 300 physicians and nurse practitioners we have in our care network that they all embraced it. This moved from a concept to every clinic embracing it in 2 years. So to repeat, learn through doing, go forth and try it. And we're, of course, here if you need any guidance and help along the way.
Wow. That is awesome. Dr. Brian Jenssen, thank you for talking with us again today.
Thanks so much for having me.
To read the paper, Accelerating Innovation in Primary Care to Support Adolescent Health Discussions, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Okay, my Say Ah is a Say Ah and a Say Yum. My backyard garden is going nuts. And we've gotten to that point that the blackberry cane is just laden with sweet, dark blackberries, and the figs are starting to come ripe, and the raspberries are ripe, and the blueberries are ripe. And so, I can walk out there, walk inside with a fruit salad.
Ooh.
And that my backyard is currently a small grocery store could not make me happier.
You know that that's lovely. I just want to say it made me very hungry. And usually my Say Ah is about food, I guess, but it's also usually about my kids. And Zelda's rolling.
Go, Zelda!
Yeah, developmental milestone kick over here because it's the first year, so we're really proud of her. It's a big moment in the house.
She's a tumbleweed.
Yes, and she's moving, which is also Say Ah.
Yeah, right. Say Ah.
Time to baby-proof. Yeah.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about the safe administration of medications in schools.
We'll speak with the author of a new policy statement, Dr. Mary Beth Mioto. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.